Thank you very much for the very kind invitation to come and talk to you about why I prefer radiofrequency to other techniques. Now, this is completely based on me and what I think of the procedures that I use. I use everything in my clinic. In 2003, when I first set up, 100% of my patients had laser. Today, 95, 96% have radiofrequency and about 4% have laser. So why this change? Well, I've only got 5 minutes and I've only got a few slides, so I'm not going to waste time or slides. And the first thing I want to show you is that picture. That's all you need for radiofrequency. You don't need a special room, you don't need special glasses, you don't need special certification. You just need that box and that device, and that's what appealed to me first. Now, the main current technologies that are competing in this arena, and for me, were the laser therapy ablation and the radiofrequency ablation, and both of these came around the similar time in chronology. But the radiofrequency actually changed to the closure fast technique, which was the reason that I took it on. What appealed to me was that it was basically idiot-proof. Essentially, for me, radiofrequency ablation is closure fast, and in using this technique, you treat a 7 centimetre length of vein in one fixed setting. It's treated all at once. The machine stops after 20 seconds. You can't treat anything else until you move it back and you've reapplied the same amount of energy. And the nice thing about the whole system is you can't control it. It's not like laser. There's a lot of argument about what wattage you're supposed to use and how many joules per second and this, that, and the other. Whereas with this technique, it's all done for you. All you have to literally do is press one button, and that's it. Now, I thought I'd present to you some of my own findings. We've heard things through the literature, and to me, listening to the literature is good, but there's nothing that beats your own personal experience. And what I did was I looked at 757 of my own patients, and 85% of these were females, as you would expect. And the age range of the group was about 13 to 89 years, with a mean of about 40. We had 450 patients who were treated with radiofrequency, which is a closure fast technique, and 265 patients were treated with endovenous laser ablation. 184 of these were using the traditional old-fashioned bare tips, and then the gold-plated and ceramic tips came along, and I jumbled them up, and 81 of them were treated using the more modern tip techniques. And in the brackets, 42 of them had radiofrequency perforator ablation as well, which I won't go into in this talk. The follow-up for all that group of patients was approximately 2 years, and they varied from about 2 months to 3 years. And the anatomical distribution of the treated veins is very similar to what I'm sure you've seen in your own practice. About 16% of them were anterior thigh veins, the majority of them were long saphenous veins, and about half of them were short saphenous veins. What I did was just monitor the pain score to start with, and I looked at the pain scores at 48 hours, and then again at a week. And patients were just given a very simple thing, and I just ticked it. And what I found was that the bare tip patients had a greater chance of experiencing either severe pain or moderate pain compared to the covered fibres, who more likely had moderate pain. Hardly any of them ever complained of severe pain. The interesting thing was that of the people who had the laser with the bare tip, 15 of them, which was about 6%, had to have early follow-up because they were in so much pain, and they were, I must be seen, I'm having a lot of pain in my legs, something awful's happened, I must have had a DVT. About 1 to 2% of them had severe pain, and one patient actually had to be readmitted overnight to have opioid treatment to try and control the pain they'd had from the laser. Using the bare tip on the 810 laser, this is the 810 laser, about 4 of them complained of moderate pain, but none of them had to be admitted, and none of them actually came for early follow-up. Now, the interesting thing was, with the venous closure, only 1% of patients actually complained of any sort of pain, and that pain was usually mild to moderate, and the average usage of pain relief was minimal. My approximate kind of gauge from talking to patients is they probably take 1 or 2 non-steroidal tablets in the first 24 hours and nothing after that. I looked at some other things as well. Skin burns were slightly more common with venous closure in the earlier days, and I don't see that so much now because I'm getting more used to the technique of tumescence and trying to push veins away from the skin. Nerve injury was actually similar in both groups, but you should note that this nerve injury was not with straightforward long saphenous vein therapies. These are patients who had residual long saphenous vein left below the knee after stripping, and that was then incompetent, causing symptoms and varicosities, and I treated that using laser or venous closure. And the interesting thing was that the nerve injury scores were actually very similar. Matting was more common with laser, and I think the reason for that was because I didn't really quite get used to the idea of switching the laser off before it came out of the skin. So now I actually ultrasound the laser until the point where it's in the vein, just before the incision, then switch it off and remove it, and I've not seen telangiectatic matting since then. We had one patient with venous closure who had a hematoma actually in the treated segment of vein that needed aspiration and was causing symptoms. Now, I don't want you to take the recurrence home. I don't want you to make too much of this. The reason recurrence was higher in the patients who had venous laser, which is 2.3% at 2 years, was because a lot of these patients had short saphenous vein treated, and at the time they were being treated, the parameters for laser for short saphenous vein were not clear. And I was using 10 watts and 50 joules per centimetre, whereas now I use 14 watts and 80 joules per centimetre. So you can see already with laser there was a question mark over what dose do I give, how long do I apply it for, whereas with venous closure, the closure fast technique or radiofrequency, it's all done for you. So if I had to give you some conclusions from this relatively short 5-minute presentation, what I would say is I like venous closure because it's reproducible. You can't change it. So if I bought my generator here and I had to treat varicose veins in Cyprus, I'd use exactly the same technique that I used back in the UK. And I'm sure people here who use venous closure in different countries would do exactly what I do. And because of that, presenting things in the literature is very easy because we know what we're talking about. We've got the fixed parameters of the treatment. Already with laser, we've been told there's different wavelengths, different joules and different machines, whereas with this, it's just fixed for you and it's comparable. And if you want to know what those parameters are for closure fast, it's 67 joules and it's 120 degrees centigrade every 7 centimeters. Okay, venous is definitely associated with less post-procedural pain, and I've seen that from my own series of patients, and it's in the recovery trial and the literature as well. And finally, what I said at the very beginning, compared to laser, venous is just so straightforward. I can take it in the boot of my car to the local cottage hospital